So the next few minutes, 20 minutes or so until lunch arrives, we have set aside as a chance for people to actually talk to each other and think about some cases. So I have case studies here that I'll hand out to different groups. So you want to get together in a group of 5 or 6 people, just feel free to move your chairs around or change chairs or whatever. You'll get one case to think about for about 5 to 10 minutes, and then we'll debrief as a group. And the questions are, do you see a role for pediatric exercise medicine from a clinical care perspective, or do you see a role for research in pediatric exercise medicine in relation to helping the child described in the case or children similar to that? Does that make sense to folks? Hopefully this will work. Okay, so I'll just kind of randomly pass things out and you guys can get. Okay, this is always the hardest part of the meeting when you let people have an opportunity to do something like small group discussions, is actually to get them to then come back to the larger group. So even though we had a lot of different groups around the room, each with a case, there's only 3 cases, so there'll be multiple groups who are discussing the same case. And so I'm just going to put each case up one at a time, and then either the folks who are discussing that case or other folks who just have some thoughts to share about it, we'll just kind of do a debrief on the discussion so that the whole group can kind of learn what people were saying in the small groups, if that works for everybody. So the first one was the mental health patient with mental health problems. So a 15-year-old boy, competitive soccer player, diagnosed, had a cardiac event at soccer and diagnosed with long QT, so he can't go back to competitive soccer. And that has caused a dramatic change in his mental health, and he's admitted to the hospital. Was admitted to the hospital, and he's now supported in the community. So wave your hand if this was the case that you were working on. Nobody? I handed them out. So that everybody had one. I know some people, like over here, flipped it over and looked at the page. Okay, so can you briefly summarize the discussion that you had around this case?
So we had a couple of key things that we were talking about. One was that this individual is supported with medication and therapy, but obviously exercise does play an important role here. Maybe not competitive soccer anymore, but what am I safe to do, what can I do, and who's going to be the provider of that information and give me the go-ahead. But also going back to the grassroots level, where now our sport model is based around, let's drive to an activity, let's do the activity for an hour, let's drive home, let's sit in front of a screen. So a lot of these kids aren't, from the young age, learning the lifelong activities like throwing a ball, skating, running, whatever, that they could go on and participate in safely. So it's like changing it from that level, teaching kids how to be involved in lifelong activity outside of their specific sport so that they're comfortable being involved in other activities.
Right. And it's very true. A lot of people these days just think about, the soccer, hockey, swimming lessons, whatever, and the sort of day-to-day physical activity that historically, come home when the lights come on, when the street lights come on, that type of freedom for kids to just do whatever doesn't happen as much. So definitely a role for physical activity counseling for this patient to help them transition into physical activity in a different context. And hopefully also, I think, this is part of the skill set that a kinesiologist can bring to it is being able to help this boy identify the triggers for him that were attractive about competitive soccer. For some people it's high intensity exercise, for some people it's teamwork, for some people it's a competitive aspect. And so if you can identify what really attracts them to that particular sport, then you can help them to find those same attraction points in other types of physical activity. Other comments?
I was just gonna say, like, maybe we could introduce him as a coach on his previous team. Kind of keep him involved with his peers and stuff like that. I think that would be very helpful.
Okay, getting him involved in another role as a coach or a manager or, you know, an organizer or referee potentially, depending on how much running they do. I know some referees that don't run very much and some that do.
Especially given his age, because he's 15, so he's in a really good position of being a role model to younger players. And that would also maybe give him a sense of purpose towards something that he's passionate about, which may help move forward.
So coaching like a younger, you know, the
Yeah.
6-year-old boys or something who would be looking up to him as a
Yeah.
competitive player. Great ideas. Was there somebody back there? No? Okay. Research related, ideas related to this, or thoughts on research? Didn't come up? Okay, that's all right. Rob Gow, who's the cardiologist here and who looks after these patients, actually published some research. He just measured heart rate in kids with these diagnoses with accelerometers. So we measured how much they were moving and what their heart rates were to see whether or not the kids were actually complying with the guidelines that they're given. And so typically they're given a maximum heart rate of 130 beats a minute or 150 beats a minute, depending on exactly what diagnosis they have and how well controlled they are with medication. And his paper that he published actually found that the kids were frequently exceeding the heart rate recommendations that they had been given. And it's actually been some of the evidence used to change the guidelines, particularly for long QT1, which have changed dramatically with the most recent guidelines issued, and they've loosened the restrictions on physical activity for this particular diagnosis. So research into practice. Okay, second one was concussion, a 12-year-old female with an initial concussion last November in a hockey game, and then additional concussions in January when she was cross-checked into the boards and then lost consciousness and fell backward onto the ice. So the diagnosis was that she's actually had 3 concussions. Moderate to severe symptoms are persisting with light sensitivity, headaches, etc. They're interfering with her ability to attend school or even do activities of daily living. There's a research study, which we know going on here at CHEO, about using physical activity early in these patients to facilitate their recovery. But she's still somewhat afraid that activity is going to increase her symptoms. So I know there was one group here was anybody else talking about concussion? Back there? Okay. Who wants to start us off with some thoughts? Do you want to start back there?
Typically, physical activity can exacerbate symptoms, make them worse. So until there's lessening of the symptoms, it may not make sense to put them into a physical activity environment because it makes things worse rather than better, even early on.
Okay, so the old guidelines that were now renewed last May, the old guidelines were called the Zurich guidelines, were saying that patients should be asymptomatic until they return to physical activity. New guidelines that came out in May from Berlin state that after 24 to 48 hours, the patient is able to return to physical activity. Now, return to physical activity, we need to be careful here. It's not returning on ice to play hockey. It's starting with a 15-minute walk and then increasing as you go. So if you're still asymptomatic after 24 hours of returning to that physical activity of walking for 15 minutes, you are capable of going to the next step, which would be, let's say, light jogging. So it all depends who is your physician on board. For her to be scared of increasing symptoms, it makes sense. However, studies have been shown to show that when you return to physical activity early on, it actually decreases symptoms, and it actually as well prevents, if you want, persistent post-concussive symptoms. So this is one of the studies that was completed by Anne Gruel in Roger Sevick's lab, recently published in JAMA last year. And so we in Roger Sevick's, we are actually currently doing the PCARE study which is to return to physical activity early on. In this study, it's a clinical trial, and the patients are returning after 72 hours to physical activity, and so we'll see the results, but afterwards to see if indeed they can return to physical activity early or not. So if she's still afraid, I think she should really start by increments.
I think that we're pretty much on the same page. The issue was that it stated that she still had light sensitivity and headaches, and it interfered with her school, and it interfered with her activity daily living. So it's kind of like that ethical dilemma. If she still has those persistent issues, at what point do you want to risk those issues increasing relative to her ability to return to her construct of health, which would include school and being able to function? So that's where I think our discussion went.
Yeah.
It was basically along the same lines, but since
Yeah.
physical activity wasn't defined as light walking, did that mean, for example, an activity of daily living, which would include light walking? If that's triggering a symptom, then we can't include light walking as part of the exercise study.
Exactly.
So that's where we were sort of
It's
discussing.
really trial. How do you say that?
Trial and error.
Yeah, trial and error with that. Like right now, this is where we're at. So as much as the Bruin statement and guidelines are saying that you need to be asymptomatic to return to go to the next phase of the physical activity within our trial, for instance, even though they have symptoms, they can still go on to doing physical activity. But the symptoms here, obviously, if they can't function with these symptoms, then they need to stop and go back a step backwards and return to that same step the next day. So for us, for what we believe, at least in our unit, and many researchers has researched, just doing really light physical activity, even though you have symptoms, it is okay, and it shouldn't exacerbate your symptoms.
And I know that we've had several concussion patients referred for physical activity counseling over the past couple of years, as well as chronic pain patients who often are in a very similar scenario where they're really fearful that physical activity is going to increase their pain. And my students have told me that the patients, they don't necessarily need physical activity counseling in terms of information, because they've been given from the chronic pain team or from the concussion team an idea of what they can do, but they find it really helpful to just have somebody there as an exercise person who can kind of partner with them till they get the hang of the whole gradual return to physical activity, as opposed to all or nothing, or trying to go at it too hard and having a setback or whatever. So having somebody there with them that's walking with them and saying, no, this is good enough, for today, this is what we start at, and tomorrow we'll do a little bit faster or whatever. Sometimes some patients can benefit from that type of additional support as well. Okay, the last one was weight management. So this is a 7-year-old boy with epilepsy that's well controlled. He's currently above the 99th percentile and on the wait list for CHEO, which is our severe obesity treatment program here at CHEO. He's referred for counseling because he seems to have a very screen-based sedentary lifestyle. Obviously, he's been referred to CHEO, so the goal of the physical activity counseling wasn't necessarily for weight management per se, although they were hoping that maybe increasing physical activity would stabilize his weight gain while he was on the waiting list. But particularly the referral was because the child seemed to be caught between a mom who was unwilling to push her child because of the way he reacted to being told to do things he didn't want to do, and she didn't like him getting angry and upset. And so didn't want to take his screens away or do anything like that. And a father who had grown up being very active and was adamant that his son was going to play every sport in the book just like he had when he was growing up. So I guess back there, since nobody's spoken from back there.
I've been elected as spokesperson. So basically the consensus among our group was that they really need a multidisciplinary team to sit down with the entire family. first and foremost to find out what the child wants, what their motivations are, what their interests are, where there's even any potential for behavior change, is what we're talking about. A social worker to sort of mediate maybe between the mother and father if they're having these sort of tense opinions or opposing opinions. A psychologist as well, or someone with a background in psychology that could sort of speak to that. And then their actual primary care physician when it comes to the epilepsy. So whoever is involved in that part of their clinical care, because it seems as though the mother is more willing to listen to their perspective. So if they sit down as a group. Oh, and I also forgot that somebody in the community, like a community coach, either of a special league team or a community team, that could hear the perspective of the clinician and also sort of speak to the mother about what they would do and speak to the father about what they would do if the son was to join their program or to participate in that sport. So it's like a very multidisciplinary approach. That was long.
Would that we would have the funding to do that?
No, that's a dream. That's a dream. That's like theoretical, but yeah. So what, like, where does that would be what best for
That would be awesome.
Yeah.
So our group spoke along the very similar lines. I think Angelica might have been eavesdropping on us.
My ears aren't that good.
One thing that came up with our group is parental education is the big factor here. Coming up with different ideas to get their son involved, but also understanding why the father's anxious, why the mom doesn't want to push, why like shouldn't let a 7-year-old dictate parental. I don't know. I'm not a parent, so. But anyways, just having that education of the parents. So if we don't have all the money in the world to provide 10 people for this one individual, then you have to start with the parents to make sure that they're educated and they understand that they're providing good nutrition, they're providing activities. Like, we're not going to pick you up from school, you're going to walk home or something like that. Like, just kind of. So some things like that, just kind of get creative in the sense of getting their child a little more moving more, a little bit more, while maintaining the clinical or medical condition, keep that involved as well.
Right. Okay, awesome. Any other thoughts on this case or research related to this case? Yes,
I guess
Sarah?
I've been helping on a study where we're working with children with epilepsy doing kind of a behavior change intervention with Fitbits. So calling them every week and trying to get them to meet step goals and teaching them strategies, behavior change strategies. So that's kind of from the research side of things, kind of what's working, what they're enjoying, if a Fitbit or something is helping them or not. So.
Oh, cool. With kids this young, or?
Yeah, anywhere from 7 to 18.
Awesome.
Yeah. So like going on that, if you know what works to change the behavior, then
Yeah,
maybe
and it's kind of getting these parents on understanding that there's a balance between just getting the child doing more than he currently is, which is not more straight to sports, right? So finding that physical activity versus exercise kind of balance and teaching the parents.
Well, and the clinician who actually sent this referral through actually called me before he officially put it into our referral system, because he wanted to talk to me about the family situation and whether or not we could, whether or not I would accept a referral like this. And it was really the focus on the family. So that even though the physical activity counselor is allegedly working with the boy to increase his physical activity while she's there, and she's doing physical activities with him, the focus of her counseling is actually with the parents, right? Which is kind of the base that you need to build before the child can then you can focus on the child. So awesome. Well, I think we're ready for lunch. So just a couple of reminders. If you haven't signed in on the sign-in sheets, please do so. If you haven't signed the consent form for being reported as part of the discussion, please do that as well. The plan for lunch would have a bit of a break now for 20 minutes until 12:30. Don't worry, you don't have to eat lunch in 20 minutes. But if you do want a break to go elsewhere, bathroom break or whatever, we have about 20 minutes where you can kind of stretch your legs and head out. And then try and get back by about 10 or 15 minutes to get your lunch, because we do actually have a lunchtime speaker. Craig Williams is going to talk to us about he's a longtime pediatric exercise researcher, but he's more recently started to work in clinical populations, and he's going to kind of talk about his research program and how he's transitioned from healthy issues in healthy children to now looking at a variety of clinical populations as one of his primary areas of interest. So just make sure that if you're heading out, for 5 or 10 minutes to stretch your legs or anything, that you get back by 20 after, 25 after, so you have a chance to get your lunch before the lunchtime presentation starts. Awesome? Thanks.